I'm not sure I know how to start. My name is Rick Altice. I'm a professor at Yale University in infectious diseases. If I could get all the speakers to come up and the moderators to come up to a panel so that we can have an open discussion and to also to get the audience somewhat involved. Karabo? Robin? Nata? So, what? And you're not to leave until I get a big hug. I miss you. So, one of the things that often happens with prisons and the array of other sort of closed settings and criminal justice settings is that they are often the poor sibling in the relationship. They're often the places where resources are the last to fall. And so if I could sort of put the question forward, we've got a ton of guidelines. They're from WHO. We've got national guidelines. We have all of those sorts of things. But what is it that we really need to sort of transform TB treatment, TB screening, all of those sorts of things in criminal justice settings in order to sort of make a difference? We certainly know that prisons, we learn from the basic science that these are crowded. There's no circulation of air. We know that there are best practices like we see in Azerbaijan where screening and repeated screenings occur, but that's in the setting of having a fair amount of resources. What do we really need to do in order to reduce the population attributable fraction of tuberculosis just from interfacing with the criminal justice setting? And maybe since you haven't been able to speak yet, you can start us out.
Okay.
And introduce yourself, please.
Okay, thank you. My name is Gumisayi Bonzo from Zimbabwe. I'm an ex-convict from Zimbabwe who has been treated for TB in prison. And I'm also an HIV positive person for the last 20 years. But I still have my smile. Thank you.
And you should.
So maybe talking from my experience while I was in prison, that was my second time of having TB. I first was diagnosed of TB in 2010, and then it reoccurred in 2012. That is the time when I was in prison. So maybe for me, I would like maybe to have partners or stakeholders, especially these meetings like these ones, these conferences, where we can actually come with the prison officers themselves to come and hear what we are saying right here, because in prison we'll never have time to talk about these things. I still remember, like what you said, when you're in prison, you lose your rights. And whatever it happens in prison, it stays there. No one knows about it, even the death, even whether people are being screened for TB, no one knows about it. So I don't know, I'm so emotional when I'm talking about these prison things. My wish is to have those prison officers to really come and actually hear about this. So maybe I would like to put it to the organizers that next time, maybe if you are going to invite us, please let me come with only one officer from the prison. Okay. So this was what I used to put on when I was in prison, and I was not allowed to leave it inside because of my HIV status and because I had TB. So I always have this with me at my house or when I'm going for conferences like this, because it's a reminder of what happened to me in prison, the stigma, this discrimination. What I didn't manage to bring is the spoon and the fork and the plate and the cup, because I was not allowed to share those things in prison. And I still remember when my first day when I went to prison, they took away my medication. And I was like, you guys, you are not serious. You are not going to change my life for the 6 months which I'm going to be here. I want my medication. So in Zimbabwe, you are not allowed to take your medication into the cell. you have to wait for the prison clinic to open. And if they open at 9, you have to take your medication at 9. If they open at 10, you have to take your medication at 10. And that time I was taking in the morning and in the afternoon. So in the evening, you have to take them at 3. So my argument was, you guys, I'm stopping taking my medication until I go out of prison. Why? Because the cycle of which you want me to take my medication, I'm not going to adhere to my medication, and I know the complications which is going to come. So the answer was, because you are inside, you don't have any rights. You don't tell us what to do. So for me, I was bold enough because I was an activist, but there are so many who were in prison who couldn't stand up for their rights. I think that is when I started having these small conversations, which sometimes led me to be isolated, because I was asking people, how are you doing? Are you on medication? How are you taking your medication? For me, I would call out to the prison officer who was outside to say, what is the time now? Is it 8 p.m. now? Because there's no watch in prison. So I used to call out. So they knew 8 o'clock, they would just call my name and say, okay, it's time for your medication. So people now started coming out to me to say, we are afraid to come out. Some were not even taking their medication. Why are you not taking your medication? There are a number of reasons why we don't take medication in prison. The nutrition thing, you don't get enough food. For me, I preferred taking my ARVs than the TB medication while I was in prison, because I could feel very hungry, and by that I was so weak. So I decided to stop taking my TB medication. So I think it's some of the dynamics which happens in prison, and I can go on and on. But I think one of the most things which hate me up to now, which I cannot change up to now because I'm no longer inside, is that the prison officers, they don't have an idea when it comes to people living with HIV in prison, even with TB, and it takes time for one to be screened. So one of my initiatives when I came out of prison was to go and look for private doctors so that we can go back to prison and ask the prison officers to say, can we come and do some TB screening? So they allowed me 2013, 14, 15. And then when I started talking about food, then they cancelled my MOU with them to say you are not supposed to talk about that in public. So it's one of the things which really is a challenge for prisoners who are HIV positive and are on TB treatment. So most of them, they just stop taking their medications. And we used to have 2-3 people being buried because of they've died because of HIV or because of TB, and nothing was said outside. No information went outside, and I don't think there's anyone who has statistics of how many people die in prison because of TB or HIV, because the information does not go out. So I think we would like to advocate for that within our government systems to say we need to introduce some policies looking at prisoners in prison getting health care services on time. Yeah, I think.
So thank you for sharing that very personal story, and I think all of your insights are terrific. I know that you and Karabo are sort of public speakers, and you're providing voice. One of the things that we've seen for HIV, and maybe Karabo, you can sort of speak to this, is that part of what galvanized, in other words, that made the move to sort of bring antiretrovirals and all these sorts of things were things like ACT and activism. But what can former prisoners with tuberculosis, how can they bring that to changing the systems from which they came? You talked about shame, a little bit, and you spoke up, but what does it take in order to have a Ryan White or activism or something like that sort of change how we think about TB and how we think about prisons?
Okay, thank you so much again. I was thinking just now that the system must not depend on one person. Like in my case, if it wasn't for the new nurse who came to replace the lady who was pregnant, I don't think I will be sitting here. So, I agree with you. The prison officials must also be engaged, in order to understand that you need to be screened and you need to be tested. Like I share the same thought. I think when you are released, you need to engage yourself with, as an ex-prisoner, I had to connect with like TB Care, from Cape Town and other organizations, to continue to actually be the voice, because it's one thing to go with me to prison and you talk to them. They will say you don't know what you are talking about. But it's another thing when you go with me and you allow me to talk, because they speak the same language. They understand the background where I come from, and I understand what they are facing. The difference is I'm now outside and I'm coming back. So I think that's what I'm trying to do back at home, to go to prisons and to leave my contact and say, look, when you are out of this place, let's connect, let's see what we can do. Then we go back as a group of ex-inmates to actually break the silence and to talk about these issues. Thank you so much.
Karabo, thank you. Yes, Robin.
I have been involved with the TB in prisons in South Africa for quite a long time, and I'm aware that if you go to the New York Times 100 years ago, in 1903, they said exactly the same thing, so things haven't changed. And we have a judge inspector of prisons, and for the last 20 years they've always said we're overcrowded. So one of the things that we did was we took a court case to the Constitutional Court to say these conditions are so bad that this is why they're getting TB, and we managed to get that established in law, that you didn't have to follow one case to another, that the conditions under which you put people were so hard. And my feeling is that you have to use everything, including the law courts, to take people to task on this. But this is not a new problem. This is a very long problem, and I've spoken to politicians about it. They're not interested because it doesn't make any difference to the people who vote for them. So I think the activism has to be very broad, but I think actually using the courts might be another way of doing it, because all of these prisons ignore their own rules.
And that is certainly true for HIV. Many of the class action court cases in the European courts, as well as in North America, sort of paved the way for some changes. So I think you're right. Broad-based activism is going to be key, not only from the community, but academics, the legal system, et cetera. Natavan, just a little bit, Azerbaijan has sort of been a candle in the dark, if you will, in terms of programs relative to Eastern Europe and Central Asia. There's been a lot of resources. There have been sort of WHO, documentations, the updated data through 2018. You've taken a lot of people in from training, but yet many of the problems in Eastern Europe and Central Asia are really unchanged. What is it that you think that needs to be done to sort of actualize what has happened albeit less than perfect, but that's happened in Azerbaijan, so that it can sort of stem the tide of what's happening in Eastern Europe and Central Asia, where going into prison is a major risk factor for MDR?
Yes, you're right. The Azerbaijan, the Eastern Europe, unfortunately, and Central Asia have a very high incarceration rate also. So this is not just we are in the Europe region and we had this problem. We had a high incarceration rate, and as I said, we have the increasing HIV epidemic in the region, and of course the drug resistance is very high. We have countries with the highest rate of drug resistance. So this is the complex problem, and I totally agree that the first what we need, that the medical service, medical care provided to these individuals must have independence. Should have independence. Only after this, the medical care could be provided on a high level. And of course, we need the funds. Yes, we're Europe, but medical services in the prison never had enough funds to do the best what they could to do, because even with the less funds, we need to prioritize our activities. And in our region, I think it's the first step is a rapid diagnostic of TB. That's why I'm pointed that even in Azerbaijan, where we have a good system, the 50% of the TB notification came from the civil society, from the civil sector. It means that only half of the cases produced, let's say, inside the prison, the half came. So we need to catch them fast and don't give them the chance to transmit inside. So we need to make some priority list how we need to spend the funds, the limited funds. And of course, I would like to say that even if we decrease, we think that this is the Euro region. We have enough money for from the government, but still we need the international cooperation inside the prison, because sometimes to speak with the penitentiary system heads, it's not easy. So we need some extra voices like the community voices and international partners' voices.
Thank you. Masood, you've spent a lifetime and a legacy thinking about prisons, and on many hands there's a lot of the science, there's at least the beginning of some of the activism that's occurring at the community level. There are international guidelines, or all of these sorts of things. But what do we, in addition to just reducing incarceration for the many reasons that it is, what do we need in order to stem the tide of tuberculosis in prisons?
Thank you. Actually, I think we should not think about TB as a separate health issue. It's also think about overall health in prison. That's something that we need to address. When you look at the prison services, their first priority is security. They don't think about the health of the prisoner, neither the health of the staff working in prison. So you need to change that way of thinking, that prison health is a public health. If you can manage to bring that way of vision at the country level, whether there should be advocacy, activism, whether there should be dialogue, whether there should be showing good example from other countries, that's the way forward. As long as this prison is the place that I'm just isolated totally, and I want to, people be closed there and then just punish them and seeing as a way of punishing the people, will not be able to change the situation. So I think it will not be one size fit all, but we need to have that kind of dialogue. That's also colleagues mentioned from Zambia and others from South Africa, to bring also prisoners and also the guards themselves, because also health of guards as well. It's not only the prisoner themselves, but also those who are working in the prison. So that kind of dialogue is lacking. So we are talking about total isolation. The Ministry of Health have their own very nice services, but the Ministry of Interior or Justice don't take care of that part. So I think our step would be political commitment at the head of states, prime minister level, and of course having the UN General Assembly is a golden opportunity. I don't know how many of you have seen the draft declaration of the that is coming out in September. 2 times it mentioned prisons and prisoners. It's already not bad, but it's not really concrete. If you really want to have an addressing the TB, should have more concrete commitment at the highest level of governments. So that's actually one thing message we could pass through this audience to address your permanent representative in New York, to try to make sure that there's some concrete measures already included in the declaration.
Setup Chief, from the union, dealing with things on a much larger level, what is it that we need to actually do? Because it sounds like this is going to be a multi-level strategy that has to happen, but with prisons being the sort of the poor step-sibling, if you will, it's out of sight, out of mind, and we've not really made a lot of movement.
Thanks, Rick. Just to add one more point to what Masood just said, it's the basic issue is that this requires a multi-sectoral coordination. Prisons doesn't come under, one single ministry or department. There's justice, there's prisons, there's police, and health actually is one of the the sidelined because they are the ones who want to take care of the prisoners, whereas everyone else feels that they don't have any rights. So health access is one of the key issues. We did a quick study, in one of the largest prisons in India, in Delhi, and we found that prisoners were actually dying more of pneumonias, gastroenteritis, cardiovascular diseases, uncontrolled diabetes, hypertension. TB and HIV were still quite low on the list. And those issues were never raised. These are all avoidable or preventable factors. And so coming back to Rick, your point, I think what needs to be done is to give more visibility. And I'm really pained, from what we hear from two of our colleagues here, who spend their time in prison and suffering the actual reality of what they had to go through. These things need to be highlighted. Prisoners also have human rights. And a lot of time these prisoners spend in the prisons is not because they have to, but because the justice is delayed. We see that there are about 10 million prisoners annually at any given point of time in the prisons across the world, but the annual turnover is about 60 million. And these prisoners stay from few days to several months. And this is the time when they actually contract TB or HIV for no fault of theirs. They may ultimately be let out saying that, no, you were innocent, it's a fault. So bringing it, on an international level. Second would be advocacy with the funders. Now, I see global funds done very well in case of Azerbaijan, where they have supported. Of course, this proposal would have come from the country, but most of the countries where TB is a problem, or the high burden countries like India, China, and so on, we do not have any TB prisons related interventions. So Global Fund as a donor, or other donors, like USAID or BMGF, need to prescribe to the countries that, no, this is a serious issue. You need to allocate certain funds both from us or from your domestic resources to address this.
So I want to build on that, because I think that final point is going to be absolutely critical as you think about how to incentivize programs. I mean, the guidelines are pretty good. They're standardized. Most countries have adopted them, but the implementation has been different. So how do we actually put those teeth to provide those incentives by international donors, but also in governments who may not be receiving that sort of high level of income? Because once again, out of sight, out of mind, not political. It's a political juggernaut to sort of spend any kind of resources on prisons.
So I think to begin with, and even I see this in case of Azerbaijan, and Masood can add that the initial step was actually taken through these, resources which are available through the funding agencies. The government may not have contributed much. But once those things are set in, then it becomes a standard of care, and the government actually is liable or obliged to continue with it or sustain it. The first step actually is the most difficult part, and I see that a lot of conversation has to be there between the Ministry of Health and the Ministry of Justice to bring this up, also with a commitment from the funders that yes, there would be a significant amount of money which needs to come in from the donors to support this.
Thank you. If I may add, Rick, also very important is that what is measured is also done. So if you look at data, the reports that coming out, you don't have that much data from the prisons. From European perspective, we have many indicators. We go there to consider how many prisoners are there, what was their treatment outcome. So that actually is very important. I think that one recommendation, one measure to take is to make sure that there is been report from countries on the number of people in prison got the TB, how many of them are cured, how many of them, when they were released from prisons, they were followed continuum of care. So that kind of set of indicators should be, stimulated and stimulating the countries to say, okay, we have to also put the resources to address this and achieve those targets. Thank you.
We've got about 2 minutes left. I will maybe take some questions or comments from the audience. I saw that hand pop up very quickly.
Yes, I've been itching to say something.
Tell us your name and where you're from.
My name is Dr. Joseph Alwach. I'm a physician. I've been dealing with TB for 50 years now. I had one of the first report on HIV in prisons in Kenya in 1978. But I think we tend to be emotional when we talk about, rather than sad, when we talk about this TB in prison. Professor Wood did a very good job about TB transmission, which could apply not just in prison prison, but even healthcare acquired infection, like in the outpatients, in the doctor's offices, in the wards. It's probably as risky, even more risky than getting TB in prison. And I feel that we too similar with prisoners too much, because after all, if you go to Africa, there are some many people who prefer to be in prison because they're assured of food every day, and they're assured of shelter, and they're also assured of proper medical treatment. If you take people in the slum, they don't have as much luxury as the prisoners have after committing those crimes. And these shelter people, and these slum people are not committing any crime. They're not assured of food, they're not assured of shelter, they're not assured of even health care services. So why do we give so much prominence to prisoners? And yet the people who are innocent and doing good job, living in shelters, don't have as much access to treatment. So I think we tend to be more emotional than scientific about these prisoners. They probably deserve more than we do. Not that I'm sorry.
Can I challenge that one? I'm sorry. I would like to challenge your point. I mean, I see your point, but as I mentioned, I mean, because the slums, they don't have good services, doesn't mean that prison should not have neither. I think it should be both the slums have good services and prison have good services.
That's fine.
Right. And I would also just challenge that even our colleagues at the end would probably say they would rather not be in prison than to be in the community and free to have the choice of health care. Do we have one more question or comment right here? Let me just take that back.
My name is Joost van der Meer. I'm an independent consultant. I've worked a lot on TB and HIV, special focus on Eastern Europe and Central Asia. So I know that region. I would like to mention a brief point and also commend the organizers of this session, by the way, and having these wonderful speakers. But my point is, we are talking about prisons, and it's not semantics, but let's add the pre-trial detention, because often that is a different ministry, it's a different organization, there's much larger turnover, and there's even less attention to health, let alone HIV and TB in prison than TB and HIV in the prison system. So let's add pre-trial detention when we speak about prisons and pay special attention to that one as well.
So thank you for bringing that up. Many people spend more time in pretrial detentions, especially in sub-Saharan Africa, than they do actually in prisons. And I will extend that to these compulsory drug detention centers, the 04, 06 centers in Southeast Asia and Malaysia and elsewhere. All of these closed settings, I think, do have an increased risk of transmission. The air circulation is not as good. The crowding is definitely higher, and the resources are just not provided. So, on a positive note, first of all, I want to thank all of the speakers for presenting today. I was moved and informed by each of you. Second, I want to thank the audience for coming here and listening and participating and engaging. And third of all, I want to also comment that each of you, of your own free will, came into the prison setting. But the good news is you all get to leave right now and go to the next session. Thank you very much.